Now let's move on to the second disease, which is disseminated intravascular coagulation. So DIC was an example of, again, a megakaryocytic thrombocytopenia only, but it is a non-immune cause. So DIC is as such not a disease by itself. Various other diseases are going to have this presentation of DIC. So in all of these diseases, there is going to be some kind of coagulation abnormality, which is going to cause lots of activation of this coagulation. So when active coagulation is excess activation of this coagulation is happening, it is going to form lots of thrombi in the small vessel. So it is an example of microangiopathic hemolytic anemia. So small vessels, there is going to be lots of thrombi. So when RBCs are passing through these vessels which are having this thrombi, the RBCs tend to fragment and break. So they are going to form schistocytes, which are the characteristic findings. So when RBC is breaking, it is called as hemolytic anemia, and since it is happening in the small vessels, it's called as microangiopathic hemolytic anemia. Okay. Then when the small vessels thrombi are going to be present, so the organ to which this vessel was supplying, it is going to be occluded by the thrombi, right? So blood supply to the organ is going to be decreased. It is going to result in multiple infarcts. So this multiple infarcts will be multiple thrombi will be seen in throughout the body. So multiple infarcts are going to be found in whatever organ it is being supplied. Okay. So that is the second feature we see in DIC. Apart from that, this thrombi is going to be continuously formed because excess of coagulation is being activated, right? So for the formation of this thrombi, platelets are being used, coagulation factors are also being used. So consumptive coagulopathy will happen. So consumptive coagulopathy, so platelets and clotting factors will start decreasing. So when they start decreasing, it is going to result in bleeding. So initially, to start with, the disease is going to have lots of thrombus. Along with that, simultaneously, the patient will also go in for bleeding. So opposite edges, thrombus is also there, bleeding is also there. So it is quite difficult to treat these patients. And as such, there is also activation of the fibrinolytic pathway as well. So fibrinolytic pathway it will be activated, and that again is going to form the that again is going to cause bleeding. Okay, so altogether, both bleeding is happening, clotting is happening, fibrinolysis is happening, everything is happening together, and there is going to be a state of consumptive coagulopathy here. So let's see the causes of this DIC. There are n number of causes. So to start with, we have sepsis. So any infections leading to septicemia, SLEs, heat or burns or physical trauma, all of this is going to result in endothelial injury. So when vessels are injured, obviously the coagulation mechanism will start to happen, right? Then in other examples of retained placenta, so usually you see a DIC in a septicemic patient or in a obstetric gynae patient, okay, OG patient you will have. So when the mother has delivered a baby, so suddenly due to amniotic fluid that can form this DIC, okay, amniotic fluid or a retained placenta or a dead fetus. So that again can stimulate the DIC. So, okay, it is these are all going to act as procoagulants and activating the thrombus formation. Then mucinous adenocarcinoma. So, already I have mentioned in the paraneoplastic syndromes of neoplasia, right? So, mucinous adenocarcinoma of the pancreas, lungs, colon, all of this mucin is going to act as a procoagulant. Then APML, which is AML M3. So, acute promyelocytic leukemia, the most life-threatening thing about APML is DIC. So there is going to be this APML, the granule contents are actually having this procoagulant substances. So these procoagulant substances, this again will trigger the formation of the thrombus leading to DIC. Then in massive trauma and severe burns as well, there is going to be lots of this injury happening with the DIC. So in all of these conditions, there is going to be a release of tissue factor. So tissue factor was the clotting factor 3, right, involved in extrinsic pathway. So both endothelial injury and release of tissue factor is going to result in the excess activation of coagulation cascade, resulting in formation of multiple thrombi in small vessels, causing both infarcts, microangiopathic hemolytic anemia, and then consumptive coagulopathy leading to bleeding as well. Okay, this is the nutshell of DIC. So when there is multiple thrombi formed in the various small vessels, those are the end organs which are being supplied by those vessels are going to have multiple infarcts. So thrombi will cause multiple infarcts leading to multi-organ failure. So the patient will go in for a failure. So the thrombi can be for any organ, brain, heart, lung, kidney, adrenal, spleen, liver, jo bhi. Okay. And in adrenal, there is something I need to mention here. If septicemia was the cause, so if there is a meningococcal infection leading to septicemia, so meningococcal septicemia has a characteristic finding. They go and cause this DIC, and in the adrenal, they are going to cause heavy adrenal hemorrhage. So adrenal hemorrhage in this meningococcal septicemia is there. So when adrenals are being hemorrhaged, the adrenal function is not going to be proper. So the steroids which are being produced, the mineralocorticoids, glucocorticoids, whatever hormones, sex steroids, all of this is going to be deficient, and that is going to result in a syndrome called as Waterhouse-Friderichsen syndrome. Okay, Waterhouse-Friderichsen syndrome is adrenal hemorrhage happening in meningococcal septicemia. So here there is going to be DIC because of this. Okay. So what are the findings in DIC? So let's see. So what will be the hemoglobin levels? So obviously the RBCs are going to be fragmented and lysed, right? So hemolytic anemia, microangiopathic hemolytic anemia is taking place. So in that case, the hemoglobin levels are going to be decreased. It's an anemia, right? So hemoglobin levels will be decreased. And in the peripheral smear, if you see, they are going to see the formation of the schistocytes, which are fragmented RBCs, which are going to have a triangular or a helmet shaped appearance. So all of this you see here, right? So all of these are example are the schistocytes which we see here, right? So whenever you get an APML case, when you are observing a peripheral smear, you have to look in for the presence of schistocytes. It means that the patient is in DIC, and if you don't intervene immediately, you lose the patient within hours. Okay. And what will be the platelet count in DIC? So consumptive coagulopathy was there. So the platelet counts are going to go down. Then if platelet counts are down, so BT will be elevated. And here clotting factors are also being used up for the formation of the thrombi. So PT and APTT will be elevated, right? And then there is fibrinolysis also happening simultaneously, right? So fibrinolysis will result in the formation of fibrin degradation products and D-dimer. So D-dimers and FDBs will be elevated in this. Then what will happen to fibrinogen, which was the product from which the fibrin and fibrin degradation products are being formed. So fibrinogen will also be decreased. Being a clotting factor, it is being used up, that also is there. And then it is also degraded into fibrinogen degradation products. So fibrinogen levels will be diminished. So this is the classical findings of DIC. Okay. So what do you do to treat the DIC? Nothing but treat the cause. You cannot control anything. So symptomatically you can manage, but until you treat the cause, there is no going back. Okay.